Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host, Dr. Rebecca Bernard, and I'm joined by my co-host and the co-author of our book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Naran Alajba.
Hi, good evening.
Today, we're talking about the dangers that patients face due to the corporate takeover of healthcare. We are joined by two experts on the subject. Dr. Robert McNamara is an emergency physician who has been publishing articles on this subject for 25 years. Dr. Mitch Li is an emergency physician with a private practice modeled on the direct primary care movement. And he wants us to raise awareness about the dangers of private equity and corporate healthcare. Both of you, we welcome you very much to the show.
Glad to be here.
When you're taken by ambulance to the nearest emergency department, you are completely vulnerable. This is not the time that you can research or negotiate prices. And with the corporate takeover of hospitals, bills for emergency services have skyrocketed. Patients often receive enormous bills that can sometimes even bankrupt them. Corporate systems are not only charging exorbitant prices, but they're also taking advantage of physicians, and in many cases, replacing them with non-physician practitioners. Mitch, I first learned about this issue from a Facebook post that you made where you really broke down a lot of the issues that are happening in corporate healthcare. Can you kind of summarize what's been going on?
Yeah, it's a long discussion. I'm sure we'll have some more here, but I think we can start with the concept that the emergency department, EMTALA, right, the Emergency Medicine Treatment and Labor Act, and it's effectively the only universal health system that the United States has, right? It is going to be the safety net, and it says that any patient who presents to the emergency department needs to be treated, evaluated for an emergency, treated appropriately, regardless of their ability to pay.
That law was passed in like 1985, I think. And I guess before that, like the hospital could turn away somebody if someone was coming in labor or had a real emergency, you were kind of out of luck. So now the idea is that the emergency room has to take care of at least patients that are unstable, right?
Yeah, it was passed in 1986. It was part of this idea that people were dumping patients. They were saying, we can't take you. And so this was the government's answer to the problem. I guess that's the best way to put it.
And that was passed, I guess, when I was passed into this world. That's when I was born. So a lot of this was, in parallel here, and Dr. McNamara has a lot of that perspective. But clearly, it was sort of needed. The emergency department and the U.S. healthcare system is broken, so we have a lot of patchwork solutions. And so this was referred to. ACEP refers to that. That's the American College of Emergency Physicians. Rightly does refer to this as an unfunded mandate. It was a mandate that emergency physicians in the hospitals have to take care of patients, regardless of their ability to pay, but it's not funded on a federal level. So the problem with that is it puts the patient into a very vulnerable situation where they can be treated regardless of their ability to pay, but that doesn't mean that they can't receive a bill and then be taken to collections and then be sent, have their credit ruined, bankrupted, or even sued.
You know what? I didn't even think about that. So the idea is that they have to treat patients, but not that they have to do it for free. So in other words, they can still send bills to patients and they can really seek collections against them. And a lot of Americans are going bankrupt because of medical bills.
Yeah, and so how we deal with that really varies upon institution, of course. And the emergency physicians might be employed by a hospital, or they might be employed by a small democratic group or a large contract management group. And the individual physician usually has very little say over how their services are billed for, or how aggressive the billing company might be with the patient. And even if they did, we don't have any control over the facility fees that the hospital bills. So this really gets to basically the beginning of emergency medicine. And Rebecca, I'm sure we can discuss this more, really, the original turf war of emergency physicians versus family medicine in the emergency department. And back in the early 90s and really in the 80s, the Rape of Emergency Medicine was published, and this was a book by the Phoenix, which was a pseudonym for Dr. James Keeney at the time, who detailed a lot of the corporate profiteering and sort of underbelly of emergency medicine. And that really prompted the formation of the American Academy of Emergency Medicine, because it was felt that these profiteering powers that started the original contract management groups were also embedded in the major specialty society, which is the American College of Emergency Physicians. The problem, in my view, is that while this was true, a lot of emergency physicians weren't really paying attention to it. And even though that's what caused the foundation of the American Academy of Emergency Medicine, it really only took off as far as membership when the wedge issue of board certified emergency physicians only, as opposed to FM physicians and others, could be members. And I think that we it's very easy for doctors to turn against one another. And basically, that was the easy wedge issue. And a lot of the corporate issues kind of took a back seat to that. And so that snowballed 30 years later or so into a really difficult situation where these CMGs are bigger than ever with an even greater profit motive than ever.
I want to just, for people listening that maybe aren't familiar with how emergency medicine kind of came to be, I think it's a fair way to kind of go back. I know Rebecca and I've talked about this a couple of times. When my father started practice in 1969, 70 timeframe, there were no emergency medicine physicians. So in our town, for example, there was one hospital. Every physician had to work in the emergency room, no matter their specialty, no matter what their scope was. And the point was then when your patients came to the emergency room, it was like an ownership kind of. Then, Mitchell, if you and I are in the same town and I'm in the Bahamas, you would therefore take care of my patient because I also was volunteering my time in the emergency room covering your patients when you're on vacation. So to be fair, it didn't matter, pediatrician, cardiologist, whatever, surgeon, you did a shift in the ER. And I remember my dad talking about this growing up. He said, I'm not equipped. A man comes in with a heart attack. I'm a pediatrician. I really need support. I'll work 2 shifts. If someone else takes the adults and works, let's split it up or something. So I will say, I think in the beginning, a lot of emergency, I'm not as familiar with the family practice. Maybe there's more of a turf war I'm not aware of, but I will say, at least in our town, there was a lot of welcome to have a specialty so that there was coverage. But you're right. And maybe Dr. McNamara can speak to this a little more of how these corporations came to power at that time.
Yeah, I want to ask Dr. McNamara about that because he's been writing about this since 1994, and Mitch calls him an encyclopedia of corporate medicine. He's the chair of emergency medicine at Temple University. He's the past American Academy of Emergency Medicine president. And tell us about when you started in emergency medicine, when you started seeing these corporate takeovers start happening in emergency medicine.
So, if you look at the arc of emergency medicine, it started with great intentions, a moral imperative to deliver care to the poor, the uninsured, to people that were arriving in emergency departments. And it just really, there's a whole history of this that you can read up on. But essentially, as stuff started to get concentrated in the hospital, better equipment, the decline of, the home visit, the ED became an area for care. And, in the mid 50s, you had we saw the show MASH, right? You have all these surgeons that come back from Korea and say, look, we did better care for injured patients in Korea than we're doing in the United States. So that was another part of the drive. Actually, a lot of academic emergency medicine was started by surgeons. So then, you created this and then, well, look, it's really getting busy. There's history articles that you can look at where the volume started to shoot up. And became recognized that we need somebody who specialized in emergency medicine. And, sort of the sad thing is that the way the specialty took off, there was a lot of, social justice type things, EMTALA, pregnant women who are poor being told to go to the county hospital. And it was almost, when you look at it, I researched the history pretty well. I started my residency in 1982, and I kind of wish I had started a decade earlier to be able to kind of stop things before they got out of hand. But there were kind of 2 pathways. One, you had the docs at the big hospitals, the academicians that were really focused on creating a specialty to serve the needs of the patients, again, that the poor, the uninsured. And then along the other side, you had the entrepreneurs who were realizing, hey, we can make a lot of money off emergency medicine by hiring our colleagues unprofessionally, to make money for us when we're not even there seeing the patient. So while we were busy creating an academic base, getting NIH funding, becoming academic departments, we were censoring each other for taking pens from pharmaceutical companies. And then on this whole other track, there was this creation of an industry to exploit your colleagues to make money off of them. And then that's morphed over time. They grew bigger, and then they sold to lay interest. And, initially to the first one was an M-Care to a company called Law, and then that later rolled to private equity. And now we have a situation where private equity is dominant. Many emergency departments you walk into, and private equity owns it. And the danger to the patients is they determine who sees you. Private equity says, what's the business decision here? Is it going to be a board certified doctor, or is it going to be, a non-physician practitioner? How can I get away with the cheapest model? Because the number one cost to delivering that kind of care is the cost of the practitioner. So the number one, that's what I tell residents. You got to understand one thing. The doctor, what they pay the doctor is the number one expense for these companies. And we've seen abuses resulting from that, where the patients aren't really getting to what we thought was important, the board certified doctor.
Let's stop and just break down a few definitions, because not everybody listening really knows what all of these things mean. So the first thing, when you say private equity, what do you mean by that?
So these are in companies where the investors put money in. They have a group of managers that look for opportunities where, in a 5 to 7 year period, the investors can get back, a 20%, 15 to 20% return on investment. In the meantime, those running the private equity firms are making money for themselves, getting healthy salaries. So private equity is basically where rich people generally put their money to try to make more money. And it's all over. I mean, it's not just emergency medicine that's fighting it. Taylor Swift's fighting it. And, my daughter's a big Taylor Swift fan. And the trouble is they come into an industry and they create practices to make money that can have negative effects. They can shut down hospitals. We saw that in Philly here with Hahnemann. There was some private equity backing there. They do what they can to profit, right? Their goal is to profit when, the goal for healthcare is to take care of the patient.
Right. So I think that this is the problem. I don't think patients understand. They think if you go to a hospital, you're being cared for by maybe an altruistic group of people that is there to take care of their health. And what I think a lot of people don't understand is now medicine has become a business or a commodity. And as a patient, you're there for healthcare, but you're actually there to make money for this system. And this system is often owned by businesses, and there's stocks that are traded, right? And things like that. So the question becomes, is there another interest besides just patients' health? When there's a lot of money at play, then that might change the way patients are being treated. And so I think that's the first thing that patients need to understand. Now, Mitch, can you explain this CMG idea? So a lot of people are talking about CMGs, which stands for Contract Management Group, right?
Sure. Yeah, that's an interesting one, because you can actually talk about definition is for probably an hour. We use CMG, and really what we're referring to when we're CMG, it's really a colloquial term. And there's a few examples that are clearly CMGs, and then the definition gets murky from there. That there are CMGs that have private equity ownership, and then there are CMGs that don't. So it's not a prerequisite to be a CMG, but it kind of makes everything bad about a CMG infinitely worse. So to further address what Dr. McNamara said about private equity, I think it deserves just a little bit more exploration, which is that private equity is kind of a special form of ownership. We have to look at the definitions of profit and profiteering a little bit. So, Rebecca, you and I both have private practices. So technically, in order for us to have a salary or to pay ourselves something, we have to have a profit, right? So there's something reasonable. There's a reasonable amount, even if you're an employee of the NHS, a physician or a government-owned system. Those doctors need to take home some kind of money in order to live. So there's profit, and then there's profiteering. And the contract management group model is one in which somebody is disproportionately profiting off the top. And that could be an individual physician that owns the group, a group of investors. It could be the public market, or in the extreme, it could be a private equity ownership. So when it's an individual physician, you could have essentially what you could call like a benevolent dictator, right? That term I think I learned from Bob a long time ago, which is, well, that is, that one doctor wants to be altruistic and they are charging a fair amount for their, work as an entrepreneur. And the patients or the doctors, excuse me, that are working for that doc might be paid fairly, and that doc may not be taking advantage of patients. But it goes downhill from there when you have a very large pyramid structure where somebody's profiting disproportionately and somebody gets greedy. So as that group grows, and they're most incentivized to grow, as opposed to a group of altruistic doctors that's not thinking about this, the more steep the pyramid structure, the more incentivized they are to grow. And we've reached this catch-22 where the most profiteering groups are the most likely to grow throughout the country. And so at this point in time, I would say, I think the estimate is around at least 50% of emergency departments are staffed by these contract management groups that I'm referring to in the colloquial sense, the ones that are profiteering, the ones that are sending patients to collections with out-of-network surprise bills and profiting disproportionately over the physician. So, I mean, we can name them. I have no problem naming these groups. And that's, yeah, go ahead.
Well, I guess my question, so obviously you, I guess, don't know that I own a private practice. It's 50 years old, actually, and we're on third and fourth generation patients. So I will tell you that in the old days, especially with like Henry Ford, for example, he set the income at no more than 10 times what his lowest employee made. And then he made sure that we bumped up, the employee's income so they could afford a Model T, for example. And that's how the Ford company kind of made their mark. And I've always really held to that. Like, I've never made more than 10 times what my lowest employee makes, even though I'm, there on the holidays, I'm writing my own paychecks, I have my employees. So to me, that's always been what's profit, right? So that's kind of what I think you're defining. And I like to define it in terms, which is, I think it makes sense to, as the CEO of my business or Rebecca's or yours, to not make more than 10 times what the lowest employee makes. So I think profiteering above that is where we're getting into millions of dollars. And I guess my question then for you is, what was the impetus for my understanding of the ER docs was they got their own management groups because they weren't getting paid well enough. They were not getting sort of autonomy, and the hospital wasn't necessarily reimbursing them properly. So my understanding was that a lot of them started their own groups and then contracted with the hospitals. I mean, do we own any responsibility for this, or is this totally just the hospitals and private equity?
Well, I mean, the problem was started by physicians, right? It was the physicians that saw the profit motive, those that got in and saw the chance to take advantage of others. I can tell you the original constitution and bylaws of ASAP, wrote in 1968, specifically said in there that you will not take the fees of a colleague, that you will earn your income from your own services to patients. It also has a line in there that you won't allow practice of medicine by a non-physician. So again, against both corporate control and also against non-physician providers, practitioners being independent. So it started out right. And the docs that started it, the 8 docs that formed it and wrote the bylaws, were independent practice. They were people that came out of family practices and decided to get together to cover an ED. But then, you've got the entrepreneurial spirits that come in and saw the opportunity. Hey, actually, if you read The Rape of Emergency Medicine, you see how it happened. Like, somebody was moonlighting at a hospital and said, look, if you can get your colleagues to work, I'll give you $10 an hour for every hour you cover with them. And they just saw the profit motive. One of them quit their residency just to go into ED staffing, and it grew and grew. And then they actually said, let's rise to power. And they changed the bylaws of the ASAP. So there wouldn't be any barrier. The academicians who should have been watching the shop were too busy, trying to create journals and research and that stuff. And the moral force of the academics was not brought to bear on the American College of Emergency Physicians. And essentially, they created a system where they shut off debate. I can actually show you a letter to the editor where they said, we are not going to discuss this stuff in the journals. They shut off the press to suppress debate. And then, the book was published, The Rape of Emergency Medicine, brought a new generation, myself and others, say, wait a second, this is going on. And once you lifted the lid, you could see that it was pretty clear there were abuses going on when we let our residents go out into the world. That's how I got involved. I was a program director. And I said, this is wrong. I mean, this world is not right where they're being taken advantage of.
Yeah, you've been speaking out about this for about 25 years. And I read one of your articles that you wrote in 1994. And you wrote that the problem had already been developing, that large publicly traded corporations had begun to acquire hospitals, and that Wall Street type contract management groups now control and employ a large number of physicians staffing emergency departments. And then you go on to say that things like government mandated electronic records, managers and administrators they use that as a tool to monitor physicians, to check on their productivity, how many tests they're ordering, if they're admitting patients, and there are certain thresholds that they want doctors to get. And doctors have begun to be influenced or coerced or threatened that if they don't comply or they don't charge X amount of dollars, that they can actually be fired or lose their contract. And
it's been shown. All right. So, I mean, if the listeners, they can go search on a 60-minute show called The Cost of Admission by Steve Croft. It was done in 2013. And there, HMA hospitals, for-profit chain, colluded with Envision MCare to basically force doctors to admit to a quota. If you were over 65 and you came in, they expected a 50% admission rate. Or otherwise, you would be threatened with your job or fired. So this is an example of the bean counters, trying to press you to be more profitable. And, we see the same thing with the non-physician practitioners. Don't interfere. Don't try to supervise. You've got to supervise them, but don't interfere. Let them operate independently. We hear these stories all the time as the American Academy of Emergency Medicine. So it's the profit motive. And that gets into what, another topic is the corporate practice of medicine. In most states, there exist laws to say businesses can't employ physicians. The same thing exists for lawyers. You don't want the business interest between the patient and the doctor. You don't want the business interest between the lawyer and the client. Yet in medicine, these have not been enforced. They have scams to get around them. And it's sorely needed. I mean, this is something that I've been advocating for a long time. I think we're starting to wake up to this. With what's going down, with private equity being more aggressive. The pandemic brought it out. Doctors that are risking their lives, getting pay cuts in the middle of the pandemic. People are starting to say, wait, why is that, Wall Street company determining staffing levels here? So it's an opportunity for, anyone listening, for the public, for doctors themselves to step back and say, why do we have private equity involved in medicine?
Well, and what do we do about it? I guess that's my question. I mean, some of us aren't involved with private equity. I mean, I'm still on paper, for gosh sakes. I practice the same way, my dad did 50 years ago. So, I mean, I've managed to survive and feed my children and my family. So I guess my question to you is, though, once they have you in your clutches, what's the solution to reverse the trend?
Well, it's to try to get all physician organizations to use the existing prohibitions out there to take back medicine. I mean, that's Mitch and I are part of the Take EM Back. So in a lot of the big states, in the home state of Envision, MCare, Texas, there's very strong prohibitions on corporations practicing medicine. They use doctors as paper owners to create sham professional associations. This was all discussed in a ProPublica article. I don't know if you saw that, where the doctor who's the owner has no idea the finances, all profits are swept. So getting organized medicine to deal with the Attorney General's office. This is the illegal corporate practice of medicine. Filing suit. Okay, now the American Academy has filed suit 4 times against corporate groups. We need to do it more. We won 3 of those 4 cases. In the 4th one, we just didn't get standing. Fee splitting. That's another rule. Okay, so technically, you're paying a part of your fee for the right to see patients in the emergency department. Again, in every state, that's prohibited. Got to bring that to light. You were aware of some federal, false claims actions on some of this kind of stuff, but it's got to collectively come from organized medicine. The AAEM is the smaller of the groups. I think we've successfully proven that you can do something. Of course, we filed suit 4 times. We've been defending doctors left and right who get fired. We've been writing to hospital administrators, don't replace the physician-owned group with a corporation. This will be a problem. So advocating, trying to take EM back, and other specialties are just as bad as we are now. I think we started it. And then, they morphed out into radiology, anesthesia, private equities in the urology, GI. It's just becoming rampant because they say, hey, we made a lot of money on emergency medicine, like dermatology. Those guys make a lot of money. We can really rake in a profit there.
Now, you mentioned AAEM and you also mentioned ASAP. So basically, if I'm not mistaken, there are two emergency medicine organizations. And the big one, as you mentioned, is ASAP, right? And AAEM is the newer, smaller, but really fighting for the little guy kind of group, it sounds like. Am I right
correct
about that?
I mean, the ASAP was formed in 1968. Okay. AAM was formed in 1993.
So one of the biggest challenges that you guys are facing is here you are speaking out about this. However, ASAP, which is the large group with probably the most power, they are maybe having a little bit of a conflict of interest here. And Dr. McNamara, you actually wrote about this back in 1994. You did this like point counterpoint article, which was so interesting, where you pointed out back then that ASAP board of directors had a conflict of interest, that they had ties to the contract medical groups, and you really were critical. And what was so interesting was that Dr. Hellstrom, who I guess is one of those people in that group, he wrote a rebuttal to you, and he accused you of, quote, innuendo and exaggeration. And he said that you, quote, attempted to paint a picture of group influence and greed that simply does not exist. This was back in 1994. All right, so fast forward to today. Obviously, you were right, because we are seeing a lot of these leaders really, with really questionable conflict of interest. And Mitch, you've actually been writing and talking about this a lot. In fact, you posted a video from, what's his name, Dr. Kevin Clower, I believe. Tell us about that video and why you thought it was important for people to see it.
Thanks. And that was a little bit of a powder keg incident. That's kind of how I would describe that event. And if I can, before I get to that, I just wanted to address a little 30,000 foot view on what you had just asked Dr. McNamara about, which is, how do we do this? And who was at fault originally? How do we get out from under the grasp of all of this? And I think one angle that a lot of physicians are familiar with is that in the BUCA plans, Blue Cross United, Cigna, Aetna, Humana, they've become profiteering, and they have. And neither Dr. McNamara or I would refute that. But what's happened is we've gotten this sort of Faustian bargain that a lot of the leaders, in that we should align ourselves with another financial giant, which is private equity, in order to fight. And right now, you just mentioned it, we have two organizations in emergency medicine. That's pretty rare. I don't think that's the case for any other specialties. In the AMA, which you might consider the joint specialty group, that represents a very small portion. I don't have updated figures. The last I saw was 15% are represented by the AMA, because largely physicians have lost confidence. It still has influence in DC because there's really no other group that has. So we're reaching that point where physicians don't have a unified voice with society. We've lost the trust of patients, and probably for good reason, because we've sold out to business interests everywhere. And so the individual altruism is kind of physicians is lost upon the public. So the problem I see is that we need to unify against private equity and non-transparent, exploitative that affect both patients and physicians within our, not just our specialty, but of course within medicine. And only then can we actually problems in American healthcare. Only then can we take on, profiteering insurance companies. So that right now, with emergency medicine sort of being the epicenter, the pioneer of this CMG exploitative model, it needs to start here. We need to unify the groups and the individual physicians against private equity, and that's going to happen with or without So I'm happy to answer the Kevin Clower video as well.
And yeah, well, what you're saying is really important. You're saying that doctors need to band together. So I think what was so interesting about this Kevin Clower video was this was a video that was about 5 years ago. And Kevin Clower was one of the presidents of ASAP, I believe, or he was a leader in ASAP. And he also, I think, was a big part of CMG, or sold out to private equity. But and I'll let you explain that. But what he was saying in this video was, doctors need to just put their heads down and take care of patients. You guys, if you do your job, everything's going to be just fine. And so I think a lot of people were really angry when they saw that, because they said, this is the downfall of medicine. Doctors are so busy just doing that, taking care of patients, and then expecting that these corporations are going to take care of us or do the right thing. And of course they don't. Is that right, Mitch? Am I getting that right? Why people were so upset about that video?
Yeah, I didn't know Kevin Clower at all. I didn't know who he was. I know he has a history, just like a lot of the forefathers of my specialty. I'm sort of learning it as we go. And to put this in context, when as a young physician, when I go to the ER, we all get a little confused, or when an older patient says, "Oh, that's cute. What are you going to do when you grow up?" And I'm going to be I'm an emergency doctor. This is what I do. Because we know the history there is what Dr. Al-Ajba had described, which is, your regular doctor goes in and meets you in the ER. And we get confused when they say, "Can you get my cardiologist in here to meet me?" And they're like, "No, they don't do that." So there's a history of EM that I'm sort of learning, right? And part of that was discovering this video with Kevin Clower. And I think it relates back to the concept of physician burnout versus moral injury. We're reframing it now, right? Dr. Wendy Dean from the Moral Injury Foundation, or Healthcare Foundation, has kind of reframed that. And burnout is very much a victim blaming, learned helplessness type term. And that's what this video, at least promoting. It was basically saying, in so many ways, do yoga and you'll be fine. It was basically saying, it was kind of an inspirational video, very well shot. And, if I were a young physician watching it, I'd probably be inspired by it.
It was actually for Doctor's Day too, which I think is funny. And, I have a little more information about Kevin Clower. This was 5 years ago that he made this video, and someone said, this is before the C-suite made millions off of the sale to private equity firm Blackstone Group. So he was part of Team Health. I guess he was the chief medical officer of Team Health. It was acquired by Blackstone for $11 billion. That's with a B. So a lot of people were saying, yeah, you tell us to put our heads down, and meanwhile, you're making billions of dollars off of our backs. And, people got really upset about that because, like you mentioned, there is moral injury. We have physicians taking their lives, and we have physicians getting out of the practice of medicine. And these kind of people are really taking advantage. And I think, Dr. McNamara, your point that the original bylaws said that we shouldn't take money from our colleagues, I think that it really comes right back to that.
If you put the perspective of emergency medicine on top of what you just said, so the emergency doctors, we're there 24/7. We're there on the holidays. We work night shifts. It's extremely stressful. We see young children die. Where I work, I see 16-year-old kids shot and killed. Dealing with the mom, it's just, it just tears at your soul. But now you have created within the specialty a feeling of exploitation. So first off, the doctors have no idea what's being billed and paid in their name. So they're in the dark. Lack of transparency breeds distrust. They see the displays of wealth that are out there with these companies. They host giant receptions. We hear leaders who are doing quite well. One leader of one of these large groups got a tower at the Ohio State football stadium named after him. It's just, and you feel like, here I am doing a difficult job and I'm being exploited. So that's really like the core reason I'm involved, being an academician training residents, because I don't think you can do a difficult job if you feel somebody's being taken advantage of you. And then you take it to the patient level. If your doctor feels exploited, burned out, they're not going to deliver the best care. They're not in the right frame of mind. It affects the doctor, it affects the patient care. And then the patients on the other end are getting these excessive bills. Doctors have no idea what the charge master is. and then they get pursued. So it just doesn't make any sense that you can't have private equity in emergency medicine.
And
we have so much more to talk about, but we're out of time for this session. We will come back on our next session and we'll hear a lot more about this. In the meantime, if you'd like to learn more about this issue, we encourage you to get our book. It's called Patients at Risk: The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. We would love for you to subscribe to our podcast and our YouTube channel. And if you're a physician, please join us, physiciansforpatientprotection.org. Thanks so much, and we'll see you very soon on the next podcast.